Good morning, everyone. First of all, I thank Dr. Hayati and the entire team to invite me for this wonderful occasion. Now, I had a similar talk about what the previous speaker has spoken. So I will change a little bit about my topic. So now, every patient, when it comes to you, so they are a little confused because they don't want that what kind of surgery you want to do. So they are just concerned that how you relieve your symptoms. So I'm going to put little more idea about my experience and how I select my patient. So for that, first of all, I would like to thank all of my teachers who are there in my progress in my career. So I learned my transforaminal endoscopy from Dr. Gore and Dr. Anterior, and I learned PECD from Dr. Sunil. He's one of the pioneers for this technique in India. And then I learned all the posterior decompression from my friend Hong. So now this is a question like, do we need surgery in all of the patients? Because you see, like I too have the anesthesia pain management background as well as the orthopedic surgery. So for first few years of my life, I used to work as a pain management doctor, and then we used to do all different kind of percutaneous procedure, and then we had some issues. We were not happy with some of the aspect, and then we went to the new modality. So I'm doing endoscopic surgery since almost last 12 years, and we do perform all kind of endoscopy. So it's not limited to one technique or something. So I always believe that you work according to the patient, and it's not necessarily that you adopt only one technique. And we all are very smart enough to understand what is right, what is wrong. So my suggestion to all of you is to just to see everything, learn everything, and you adopt your own technique. This will help you. Otherwise, it will happen that you will be just guided or misguided by your teachers, and you will not be able to learn what is correct for your patient. So if you are not happy with your own result, just try to change. So now we see that this is the most important slide for this presentation, that I divide my patient into two. The one group of the patient, those who are having the chemical inflammation. So the patient will have more for tingling or paresthesia, and they have a severe pain. So the pain is mainly mediated by the cytokines, and the pain is not the indication for the surgery. This is very sure. So if you are able to reduce the inflammation, the pain is going to go away. So only the indication for the surgery are the patient, those who are having the mechanical compression, and your result will be great in those group of patients only. So I see the patient who are having the inflammatory symptoms or the compressive symptoms, and depend upon that I divide. And we all know that the disc is only pain sensitive only in the outer 1/3 of the annulus. So unless the patient doesn't have more than 2/3 of the annulus rupture, they don't present with the symptoms. So when they present with the symptoms, it means they already have the 2/3 of the annulus is broken. Now you have to decide what to do. So the main reason for the inflammation, which none of the radiological investigation is going to tell you, is about the cytokines. And now we have identified that it's a proteoglycans A2, which is a very powerful chemical inflammatory mediator, and it will produce intense inflammation, and it will produce a lot of pain to the patient. So this content of proteoglycans A2 is 10,000 times more into the disc rather than the blood. So when the disc herniates first time, so you must have seen the young patient when they have the acute symptoms. So they have the very severe inflammation. So now we understand that there are only two possible mechanisms in the body to have the pain. One is the inflammation. So you see all appendicitis or all cholecystitis or any kind of inflammation will only produce pain. And the second mechanism is a distension. So distension will produce a nerve stretching. So this is also the reason that the patient will have pain. So here in disc herniation, both of the things are happening. Inflammation is coming from the annulus material, and there is a pressure on the annulus, so the annulus breaks out. So there is a continuous pressure on the annulus, and annulus distension causes also pain. So now, if I have any patient who comes to me, so I divide the patient into the two groups. One is if the patient is having the discogenic pain, or the patient is having the radicular pain. So if the discogenic pain, then my approach for those patients is to do the cervical. So I say it's a cervical lavage. Cervical lavage means we just do the injection inside the disc. So this takes care of the discogenic pain, axial pain. And I tell you, I have the wonderful experience of the group of the patient, and they are doing excellently well. So if you don't have any motor symptoms, you can just do like this. So for the axial pain, so axial pain with the radicular pain. So even the cervical pain can also be there up to the lower angle of the scapula. So C6-7 pain can radiate. So it's a referred pain from the C6-7. I have seen the big number of patients coming with the thoracic MRI and everything, and they are not able to find out anything. So this disc lavage is going to tell you about diagnosis also, because you are inside the disc. So this will have the kind of a discography-like effect. And then once you, so what I do, you can see here. So I take the contralateral side. So I go from the left for the right side symptoms, and the left side for the right side symptoms. So you see this, I reach inside the disc, and then I take the combination of the local sensory dose of the local anesthesia as well as the anti-inflammatory, and then I keep on injecting. So that injection pressure, I feel that this is my injection pressure. So what is the advantage here? So this is also true for the lumbar, that when you inject inside the disc, so this your anti-inflammatory in the local anesthetic solution is going to take the same path of inflammation. So this is going to feel your disc, then it will pass through the annulus tear, it will pass through the PLL, it will pass through the epidural space, it will pass through the nerve. So this you cannot achieve with the epidural injection, or you cannot achieve with the selective root injection. So the axial pain, discogenic pain with the radiculopathy, you can do it very well with this. So you can see this is a AP view and this is the lateral view. So your target is the posterior vertebral line. Now you have the different group of patients who are having only radiculopathy. So in a radiculopathy patient, again we do like this is called the neuroplasty. So you go from the opposite side, contralateral side. So you have the better chance because of the better trajectory, better angulation. You can pass the catheter to the lateral canal, and you can see this should be the nice the root coming out. So you can inject only when you are able to see your medicine is have the safety valve. So when you inject more, the more medicine will come out, because you don't want to increase the epidural pressure, because you can have the adverse effect. So now we talk about only the patient who are having the pain as a major symptoms, not the motor weakness. So now for the motor weakness patient, we do the two kind of approach. One is anterior approach, one is posterior approach. So I select this PECD mainly for the soft central cervical herniation. Again, because we do the disectomy with the posterior approach also, but taking care of the central disc is difficult. So if you have the large disc, central disc, it's better to go with the PECD. So I will not go into the detail, but these are just a small technical aspects. So this is the position of the patient. So especially when you have 5-6 or below herniation, this is the position, because shoulder will always come in between and you will not have the idea. Now, so this was the MRI, this was the herniation. So now you see, there was a question that about esophagus injury or something. So any anterior cervical injection, when you are doing, so you have to be very careful about two structures, esophagus and the carotid. So what you have to do, that you are putting your hands and you are making sure that with your fingertip you are able to palpate the anterior part of the spine. So you are able to palpate the anterior part of the disc. So when you are putting the first needle or first any instrument, there should be nothing in between your needle and your so the skin, and then directly you are on the anterior part of the cervical spine. Second thing, you can always ask your patient about the deglutition. So you can ask that is there any pain while deglutition. So normally I do all of my anterior cervical disectomy under local anesthesia. So this is quite possible, and luckily also we don't have any esophageal related injury. And then you can see the disectomy in awake patient. So initially I used to do the endocarmine, and then we used to just remove the disc. So the good thing is when your patient is awake, you are very sure, and because we all believe your awake patient is your best neurological monitor, and they can give you all kind of feedback. So even you can stop sometime if you have any issue. So you can see this is the depth of the instrument. You can go up to the half of the facet safely, and since you are doing everything under vision, so you don't have to worry about injury. And again, all of my patients under local anesthesia, so I'm not worried about any neurological complication. And you can see this is the end point where you can see the inside. So currently the problem with the cervical endoscopes, because of the endoscope is very small, it's around 4 millimeter endoscope. So the optics is difficult. So you cannot get the same vision what you're going to get with the big lumbar scope. So you can see this will be the only small cut. And you can see this is the post-op MRI immediately. You can see the post-op MRI. So this was also like pre-op, post-op. You can see the up and down. So now the indication for the anterior cervical disectomy was only the states of cervical disc herniation. But now we do have some new instruments, and with this we are using some angle or some flexible instrument which are helping us to do the. So we have even 2 millimeter now carries, and also we have the small hook. So that helps you to track the herniation from the different part. This is also the 2 millimeter curette, which is also very helpful. Now this is something very interesting for all of you, that after doing any disectomy or decompression, we like to inject the PRP. So normally what we do, we take in the same operation theater, we take the 15 ml of the blood, put 200 to 300 unit of heparin, and then we just withdraw the liquid form of plasma. So this we always inject inside the operative site. So this helps you in the 3 ways. This is a very powerful anti-inflammatory. So it just help you to take care about the local inflammation. Since it's having the platelet, so it also stops the local oozing of the blood, and also it contains the growth factors. So because of the growth factors, it also helps to take care of the minor concussion or minor injury, or maybe if you have some small dural tear or something which are not noticed, this can be taken care, and this doesn't have any side effect because it's coming from the patient's own blood. So now posterior decompression. So like I do 3 procedures with the posterior decompression. One, if the patient is having the bilateral symptoms or the myelopathy, we do the bilateral decompression over the top. And like what Professor has said, you can do with the same incision over the top. So yesterday I think there was a big group we did in the cadaver workshop. All 3 procedures in from the one incision. So if the patient is having the bilateral symptoms, you do the posterior decompression. So here, if you have the chronically plaque disc on the MRI and the patient has a long duration of symptoms, you don't touch the disc. Because the moment you touch the disc, you are opening the Pandora and there are more chances of the herniation will come out. So even in those patients, the posterior decompression is more than enough. If my patient is having more of a radicular symptoms, then I do the unilateral decompression with the foraminotomy. And if the patient is having the foraminal herniation, paracentral herniation, you can, and especially the acute herniation, you can do it with so if the patient is having the stenosis with the herniation, I go with the posterior approach. So I'll just show you one by one. So you see, this is like my first case before almost 6 years. So this was the patient who was having myelopathy. He used to fall while walking. Very old gentleman from Africa. So we use this 8.4 millimeter endoscope, and these are all the equipment. So now you see. So still, I also do all this surgery under local anesthesia. So we do have the special technique, and we have done thousands of the cases under local anesthesia. So you see, this is how we do it. So you first dock. So you see, this is the only area where you are docking. This area, if you may make it pain-free, then it's very easy. In bone, only the periosteum is pain sensitive. So if you infiltrate the periosteum, you can just drill everything, and then you identify the structure, and then once you identify the bone, you start the drilling. So the good high-speed drill is very important for doing the cervical decompression. So you can see how precisely your drill can work, and especially diamond tip is very useful, because diamond tip will make the bone into the powder, and it will also seal the bone, so your bleeding chances will be very less, and most important, diamond tip doesn't affect the soft tissue. So this is a good idea. And then you can see, once you do that, so your bone drilling you have to do till you are able to put your kerrison inside. So then with the kerrison you will be able to do the decompression, and the amount of the decompression, the ligamentum flavum will be able to identify you that how much decompression you need to do, and adequacy of the decompression, you can visualize the lateral part of the cord and the root. So this is the principle. Again, the bony work with the drill you need to do till you are able to put your instruments. So then with the kerrison you are able to do all of your work nicely and precisely, and then how much decompression. So it's depend upon where you get the ligamentum flavum and where you are able to completely decompress the flavum. I already took the permission from Hayati. I will take little more time. Sorry for this. No, let me finish. Because you see, this is very, very important, because you see, we just show you what we are doing, but the indication, how we select the patient, what is more important. So like you see, this is the drain I always put for any posterior surgery, and you can see the patient is awake. So this I will not go. So I have like 4-year follow-up for this patient. Now patient is doing fantastically. So now this is also, we do the cervical disectomy also. So for the soft cervical herniation and the foraminal herniation, so we do have a very special root retractor, where you can put the retractor there, and you can just make a small stab with the Indian knife, and you can see the disc will just come out. So this is also like very, very safe, because here you don't have much space. So with the scope you cannot use the two instruments by retracting and doing the disectomy. So here you can see this is the herniation. So once you grab the herniation, you can see the nice piece of the disc will come out. So in this particular patient there were two disc fragments. So the good part is then you can also seal the annulus also. So you can see this was the first fragment. So I just want to show here that this is the root retractor, where you can now, so it's like a half circle. So you can just put it, and then you can rotate it back, and you can take it out. So then you will be able to visualize the root nicely. Yeah, so you can see now I'm removing this. So now you can visualize the cord and the root. So this is the X-ray picture. So you are very sure that you are on the exact side of the disc. So you can take the lateral view and check the confirm. And the foraminectomy for discogenic pain as well as for unilateral radicular patient. So you can see this is the way you can do the nicely decompression and foraminectomy. And yeah, so I think now I'm okay. So again, like the cervical, if you have done the good number of lumbars, the cervical is faster and more easier as compared to the lumbar, because the cervical lamina are very thin and your work is very fast because the bone work is also very less. Ligament of flavum is also very thin and the depth of the lamina is very small. So the only thing current problem is about anterior cervical disectomy. What we are facing is the availability of the good scope and the optics. So we are working on it, but soon this will also be available. Thank you.
Thank you very much, Shiraz. That was a beautiful presentation. It was due to the time constraint. Otherwise, we would have loved to see all the videos which you are presenting.
No, but I took the permission before also that I will finish my
Yeah. So we will take a quick question from Samir.
Thank you for the excellent presentation.
Thank you.
And my question about lavage that you are talking about. As you know, disc itself is more innervated. It's just a sino-vertebral nerve, and the pain doesn't come more from the disc itself. It's because release of cytokines from others. It's the reality. It's poorly innervated. Disc is poorly innervated.
No, you see, there is no pain possible without the inflammation. So even the MRI, when we take the MRI, so it's not the loading position. So the discogenic pain, the pathology is there is a minor angular tear, and through the tear, the disc leaks out. So that's why the MRI is not also very sensitive. And this cytokines produce the nerve inflammations, the sinovertebral nerve or the root, and that produce the different.
I'm talking about cytokines doesn't come from the disc itself. It's from the structure of the part. You can review it later. But my question about if you inject or doing this lavage, how could you be sure that these cytokines will be affected? Second, about the esophageal. Yes, the esophageal tear. You are talking about pushing it by your hand. This is already discussed in literature, and this is already the procedure. But you can't be sure. You are going
the complications are the part of the procedure. If you don't accept the complications, so like you ask the same question with the previous speaker. So he has his answer. I already given my answer. So that is a complication. See, I'm lucky. He's lucky. We don't have this. So just for the sake of the complication, we can tell the audience that this is a likely complication. You will be aware. But like see, we have done the enough cases, and this, if you take care, awake patient, ask the patient all the time, even during the surgery also, we have the cannula, dilator, everything inside we are doing. We keep on asking the patient, do the deglutition, and if it is not a problem, this is a problem, even this will get unnoticed, and you are perfectly right. But you see, like this question you already asked, and this is the answer.
It's risk-benefit ratio. Okay? What is
No,
the
but
issue?
how many you have done this? How many you have done this procedure?
I am asking
No, see, this is the problem. Just from the literature and just from somebody else's experience. Yes.
It's
So I accept this is a complication. This can happen. But see, when we are doing it and we are giving you the logic behind it. So like see, we have done around 50 cases of anti-cervical. So I understand this is not a big numbers. But if you ask those who are doing it, so nowadays because of the posterior cervical instrument, now we are doing less and less number of anterior cervical. But touch wood, we are lucky with the grace of Almighty Allah. We haven't got this. But again, like this is a complication. There are so many other major complications can happen. But like, see, this is a forum where we are talking about the different aspect of the procedure. And see, even now we are doing the posterior decompression because of the same issue. Because see, like when I'm putting the needle and dilator inside, my all sphincter are very tight. I know. So that's why when you have some better procedure, and this is the part of evaluation, it will always come.
Yes, this is always a worry in surgeon's mind about the esophageal dehiscence in these procedures, but usually it does not happen if you stick to the technique. There have been wonderful studies where live MRIs were done by putting the pressure on the vertebral body. What happens is when the trachea is shifted, the esophagus turns in angle and it gets out of the way. So thank you, it was a wonderful discussion. Thank you, Shiraz. We are running a little late and we are behind time. So we will just have a quick break for a coffee and we will go to the next session. Thank you.